I'd like to welcome everyone to, this is the GW Biomedical Cross-Disciplinary Seminar Series, and it's co-hosted by the Department of Integrative Medicine and the Department of Pharmacology and Physiology. I'm one of the co-hosts. My name is Paul Marvar. I'm an associate professor in pharmacology and physiology. My co-host is Dr. Lee Frame, and she's in the Department of Integrative Medicine. And this is the inaugural year for this seminar series. And the seminar series focuses on inflammation and chronic disease. So we have researchers, clinician scientists from every facet of disease, from cancer to colitis to neuropsychiatric disease disorders, and today in particular, the focus is on cardiometabolic disease, in particular hypertension, high blood pressure. And with the goal of the seminar series is to not only promote networking and collaboration from across disciplines, with the idea that we could learn from each other, but also seeking a cure to therapeutic approaches, new therapeutic approaches for developing a strategy for prevention, as inflammation, as everyone knows, is a major facet to disease progression across the spectrum. And as I mentioned, today we're going to be talking about cardiovascular disease, and it gives me great pleasure to introduce Dr. Meena Madhur from Vanderbilt. I've known Meena for some time now. She's a very good colleague and friend. And thank you, Meena, for being here today to talk about your work. Meena has been an associate professor since May 2020 in the Department of Medicine, Division of Clinical Pharmacology and Cardiovascular Medicine at Vanderbilt University. So she's coming to us from Nashville, Tennessee. She's been at Vanderbilt since 2012. And Meena is a true cross-disciplinary scientist, being the theme of this seminar series. Her undergraduate degree from Duke University, she's a double major in biomedical engineering and biology. She received her MD PhD in 2005 from the University of Virginia in molecular physiology and biological physics. She went on to do a residency in internal medicine at Duke University and her fellowship in cardiology at Emory University. So Meena is a remarkable scientist, clinician in the cardiovascular medicine field, and she's won numerous awards and grants and in the area of inflammation and hypertension. I want to point out one in particular award that she received in 2019 under the Obama administration. She received the Presidential Early Career Award for Scientists and Engineers, which is, again, a remarkable testament to her career as a clinician scientist. And she's heavily involved within the American Heart Association, and she's received awards such as the Established Investigator Award, the New Innovator Award, and these are all important awards in which she has been awarded in the area of inflammation and hypertension. And she is one of the pioneering researchers in this field in terms of understanding some of the underlying immunological mechanisms in which the immune system contributes to hypertension. So her work is really focused on identifying how to harness and understand the immune system in the context of cardiovascular disease development and hypertension, and coming up with new therapeutic opportunities with that. So without further ado, thank you again, Meena, for coming to us today to talk about your work and the progress that you've made in this field. So without further ado, I'll let Dr. Meena Madhur take over. The title of her talk is T cells turn up the pressure.
Thank you.
And I will just say too, if you have questions at the end, we'll have some time. Just put those in the chat box. Feel free to turn on your camera as well, and just we could do a Q&A that way as well. So thank you, Meena.
Great. Thank you very much, Paul, for that introduction. And thank you for the invitation to speak today at this seminar series. I wish it could be in person, but perhaps maybe next year we'll have more in-person meetings. So I wanted to start with a map of the problem I'm going to discuss today. So who knows what this is a map of? Does anybody want to venture a guess? Is it the map of the election? I mean, I know Trump would wish it was, but is this a map of the coronavirus cases? I mean, it looks very similar to the coronavirus map, but actually this is a map that shows the percentage of people across the US that have high blood pressure or hypertension. And as you can see, it's concentrated down here in the Southeast, but it's really all over. And basically 1/3 to 1/2 of all adults in the United States, and more than 2/3 by the age of 65 have hypertension. So this is a major problem. We know that about 1/3 of cases of hypertension are related to increased salt consumption, and that increased blood pressure was the cause of 50% of heart disease, stroke, and heart failure. So this is a significant issue, and it's not just in the United States. So this is from the Global Burden of Disease Statistics. So worldwide, in terms of leading risk factors for death, high blood pressure ranks well above all the others, including smoking and diabetes, air pollution, obesity, etc. So you might be wondering, how does cardiovascular disease and hypertension relate to COVID? So this is actually a comparison I thought was interesting to make of the deaths per week across the last 5 years related to heart disease, cancer, and the other major causes of death. There is a cyclical pattern, as you can see here, to heart disease, which is also fairly interesting, that coincides with the cyclical pattern in deaths due to kidney disease, suggesting that these two are certainly interrelated. So COVID-19 came on the map in early 2020, and at one point in April, it actually did exceed cardiovascular disease as the leading cause of death in the US. But it has since come down, and we'll see where it ends up, but currently COVID-19 is the third leading cause of death, and cardiovascular disease is still the #1 cause of death in the United States. And as I mentioned, hypertension is the #1 risk factor for cardiovascular disease, so it's important that we talk about hypertension today. So the outline of my talk is as follows. I want to give you some historical perspectives and also discuss the current definition of hypertension, and then talk about some work in our lab and other groups on the role of the immune system in hypertension, and then some current treatments for hypertension that may actually alter immune function that you may not have realized, and then whether immune modulation and an inflammatory target as opposed to a blood pressure target might be in the future for the management of hypertension. So let's start with some background. So in 1911, Dr. Fred Mohammed and Otto Frank coined the term essential hypertension, implying that the elevation of blood pressure was an essential compensatory reaction to overcome ischemia of tissue caused by constricted arterioles. Then 1912, Sir William Osler addressed the Glasgow Southern Medical Society and made the following statement about high blood pressure associated with atherosclerosis. And he said that in this group of cases, it is well to recognize that the extra pressure is a necessity, as purely a mechanical affair as in any great irrigation system with old encrusted mains and weedy channels. So get it out of your heads, if possible, that the high blood pressure is the primary and particularly the feature to treat. So it was hard to believe that 100 years ago, we thought that the high blood pressure was actually part of normal physiology and that we did not need to treat it. And in fact, in 1931, even, John Hay said, the greatest danger to a man with high blood pressure lies in this discovery, because then some fool is certain to try and reduce it. And Charles Freiberg said that in a patient with mild benign hypertension, which he defined as a blood pressure less than 200/100, there was no indication for the use of hypotensive drugs. and that continued observation was desirable, and conservative treatment consisting of reassurance, mild sedatives, and weight reduction was indicated. So he did get the weight reduction part right, but that was about it. So in the 1960s, we also thought that hypertension was part of normal aging process, and that an age plus 100 was considered the normal blood pressure level. So if you were a 70-year-old man, we thought that a blood pressure of 170 was perfectly physiological. But then in the 1960s and 70s, some landmark clinical trials done in the VA by Dr. Edward Fries showed that indeed drug therapy can reduce cardiovascular events in patients with a diastolic blood pressure of 115 to 129 or between 90 and 114. And at that time, they were really focused on the diastolic blood pressure. It's only more recent that we've come to realize that systolic blood pressure is also probably even more important than diastolic. So we now know that hypertension is indeed a major modifiable risk factor, and that in clinical trials, we've shown clearly now without a doubt that if you treat hypertension, you can achieve a 35 to 40% reduction in stroke, between 20 and 25% reduction in myocardial infarction, and a more than 50% reduction in heart failure. But is this enough? Because now, and it may not be, because what we do still know is that treated hypertensive individuals who have a normal or high normal blood pressure still have twice the risk of developing cardiovascular disease compared to their untreated counterparts with similar levels of blood pressure. There's something about having the diagnosis of hypertension where even if you get your blood pressure down to normal, you still have an elevated cardiovascular risk. So can we fix that residual risk? So the question that are still remain when it comes to hypertension is, how do we define it? What is normal? And how low should we go? What is the ideal blood pressure goal? And how do we get there? And maybe this is making you feel confused or lost and perplexed, and if so, you're not alone. The blood pressure goal has been a moving target for many years. So we initially thought that the blood pressure goal of 140 over 90 was pretty good. And then later, he put the idea that maybe if you're older and if you're diabetic or have kidney disease, we said 135 over 85 is a better goal. And then later we thought, well, if you are certain older people, 150 over 90 might be fine. And then with the SPRINT trial, it kind of revolutionized our thinking, which suggested that blood pressure less than or equal to 120 was actually more important to achieve. So currently, the current ACC, AHA guidelines are that a normal blood pressure is less than 120 over 80. And then we call an elevated blood pressure between 120 and 129 systolic and less than 80 diastolic. And then stage 1 hypertension is now a systolic blood pressure between 130 and 139. And then stage 2 hypertension is a blood pressure more than 140 over 90. So I just say that I want to discuss what is the normal blood pressure? How low can we go? So there's an interesting paper that came out this year that showed the association of normal blood pressure levels and its risk with cardiovascular disease, to see if maybe, there was some plateau where below a certain point, you are fine. And interestingly, what they found was that no, it's a gradation. So they looked at people with different groups of blood pressure. So people were divided into blood pressure groups of systolic between 90 and 99, or between 100 and 109, or between 110 and 120, or between 120 and 130. And they saw that in each of these 4 groups, there was a stepwise increase in the amount of coronary artery calcium, which is basically a marker for coronary artery disease. And when they graphed the adjusted incidence of cardiovascular disease hazard ratio by systolic blood pressure, you can see here that even as low as 90 seems to be beneficial. So there really is no bottom level, and it's definitely a gradient. So our cutoff of 120 is rather arbitrary, and the lower you can go, the better. So what is the role of the immune system in hypertension? And could this offer clues to helping with the problem of the residual risk that people with hypertension have? Well, we believe that hypertension is actually a systemic process, and it's a systemic inflammatory process, which affects almost every major organ and vessel in the body. So what we're measuring in the clinic or in the hospital is this high blood pressure that we can easily see. But what we're not always measuring or treating is the what underlies this iceberg, which is the renal inflammation and vascular inflammation. and central nervous system activation, oxidative stress, activation of dendritic cells and monocytes, so innate immune cells, activation of T cells, which I'll talk about today, and cytokine production. And we think that it is these underlying factors that are not always addressed by our current treatments that is causing the residual cardiovascular mortality in people with hypertension. So perhaps we need to rethink our goals, and perhaps we need an inflammation goal to target in hypertension rather than some arbitrary blood pressure number. So what is the pathophysiology of hypertension? We know that the kidney is very important in regulating salt and water and therefore blood pressure, that the heart and blood vessels are very important in vascular tone and systemic vascular resistance and controlling blood pressure in that way. And the sympathetic outflow from the central nervous system also controls these other organs and regulates blood pressure. So based on this understanding, our current treatments for hypertension are, of course, diuretics and RAS inhibitors, and then drugs that target the cardiovascular system, like beta blockers, calcium channel blockers, vasodilators, as well as central sympatholytic agents. But we now understand over the past 10 to 20 years that the immune system plays a very important role in hypertension, and that both innate and adaptive immune cells can infiltrate these various organs and release factors locally called cytokines that then have direct effects to cause further increases in blood pressure in basically a feed-forward cycle and to cause the vascular damage. And really, people don't die from having a high blood pressure. They die from the consequences. So from the kidney dysfunction and from the renal and from the vascular and cardiac dysfunction. And we have no therapies for hypertension that specifically target this inflammatory end organ damage. So what are some early studies that link the immune system to hypertension? So in 1964, so even before we knew that it was important to treat hypertension, White and Grohlman showed that the immunosuppression could attenuate hypertension in rats with partial renal infarction. And then in the late 1960s, Okuda and Grohlman showed that there were autoantibodies to kidney tissue in animals, that if you just transferred lymph node cells from a rat with a renal infarction into a normal recipient rat, that could induce hypertension in the recipient rat. So just transferring lymph node cells was causing hypertension in the recipients. Then in the 70s and 80s, Svensson and Batalard showed that thymus was important in developing hypertension, and they would take out the thymus from rats, and this caused a protective phenotype. However, for some reason, the immune system and hypertension was not really studied much further in the 90s and early 2000s until it was revisited by Dr. David Harrison and his group in 2007. And what they showed was that mice lacking recombination activating gene 1 or RAG1, these mice were protected from hypertension and vascular dysfunction. So RAG1 is the gene that's important for the immunoglobulin recombination. So therefore, RAG1 deficient mice basically lack functional T and B lymphocytes. So it's a model of immune deficiency. And what they showed was that the blood pressure in response to angiotensin II, which is our common model to induce hypertension in the animals, goes up like a human from 120 to 160 in a wild type animal, and this is blunted in a RAG1 knockout animal. But if you give back T cells, but not B cells, this is able to restore the hypertensive phenotype, thus establishing that T cells are indeed important in hypertension. And this is also shown again by a group from Duke using skid mice, as well as a group by David Mattson's group showing that RAG1 knockout rats have a similar protection from hypertension. So where are the T cells? So we did some immunostaining. This is both from the original Guzik paper as well as a paper from our group recently, to show that you can see these T cells, CD3 positive T cells around the glomerulus in the kidney. They're also scattered in the medulla. And then the blood vessels, we see them around the perivascular fat. So we now know over the past 13 years since an initial paper came out by Dave's group that several different innate and adaptive immune cells contribute to hypertension. And in particular, my lab is focused on the adaptive immune side and looking at CD4 positive T cell subsets, and as well as CD8 positive T cells, which make interferon gamma. and also T helper 17 cells and gamma delta T cells that make the cytokine interleukin 17A, which we think plays a very important role and maybe even a central role in hypertension development. And then more recently, and I'll talk about that briefly today, we looked at some cells called T follicular helper cells, which make the cytokine IL-21. And IL-21 can also be made by these T helper 17 cells as well. And these TFH cells are very interesting because they are the cells that provide help to B cells. And the role of B cells in hypertension is somewhat controversial. So through the years, we've shown that that T cell-derived cytokines indeed promote hypertension. So these are several different mouse models that we've used where we knocked out IL-17A only, or interferon gamma only, or IL-21 only. And as you can see, knocking out any of these cytokines just in isolation provides some protection from the increase in blood pressure that we see with angiotensin II infusion. We also showed that if you take wild type or IL-17 knockout aortas, and then you make a single cell suspension, so we use collagenase to digest the aortas and they filter them, we have a single cell suspension, and then we can do flow cytometry to quantify the immune cells. And when you do this, a wild type animal has a 2 to 3-fold increase in immune cells in the aorta. And this is completely abrogated in the IL-17A knockout animals. And also, this is kind of a summary slide, just going through the different experiments that we and others have done throughout the years. So the IL-17A has profound effects on vascular function. So basically, it can directly affect eNOS phosphorylation, and it can increase ROS, and that leads to a decrease in nitric oxide, and that leads to impaired vasodilation. And then IL-17 can increase collagen synthesis, which leads to vascular stiffness. And then also we show that IL-17 can increase chemokines in the vessel, which is important in the recruitment of other immune cells. So it's not just that if you knock out IL-17, there's no IL-17 producing cells in the vessel, there's actually no other cells in the vessel either. So it really dampens the entire inflammatory response. More recently, we want to look at the role of IL-17 in the kidney dysfunction associated with hypertension. And so to do this, we have this protocol where basically we can inject mice with a saline bolus IP that's equal to 10% of their body weight. So for example, for a 25-gram mouse, we would inject 2.5 mLs of saline into their belly. And then we wait 4 hours and place the mouse in the metabolic chamber, and then we collect the urine. And then we can measure the urine volume, sodium chloride content compared to the total injection given. And when you do this to a wild type animal, you see that after Ang2 infusion, so when they're hypertensive, they're unable to excrete as much of the volume that you give them and as much of the sodium that you give them. So basically, a wild type animal after Ang2 infusion is holding on to salt and water. And remarkably, by not having the IL-17A cytokine, these mice were able to excrete, the same amount of salt and water as if they had not seen any angiotensin II. So we asked, how is this occurring, and what is IL-17 doing to kidney sodium transport? So long story short, I'm going to just show you the summary slide from this paper, but we investigated different proximal and distal sodium transporters. And what we found was that IL-17 in the proximal tubule was increasing the expression of NHE3, which is a sodium hydrogen exchanger 3. And that in the distal tubule, IL-17 increased the sodium chloride co-transporter NCC and ENaC through an SGK1 dependent mechanism. So thus, IL-17 is having direct effects on the kidney to regulate sodium transporters in the kidney, and thus salt and water regulation. And we're not the only ones that have seen this. So several other groups have shown that different cytokines like IL-1, IL-6, interferon gamma, etc., has different effects along the nephron to regulate salt and water absorption. So it's very fascinating that inflammatory cytokines are controlling different aspects of our kidney function. And recently, we've gotten interested in how salt affects the immune system. And there were 2 papers that came out in Nature about 7 years ago now that show the salt can drive these pathogenic Th17 cells through the salt sensing kinase SGK1. So we always thought of SGK1 as being important in the kidney, but now these groups show that SGK1 is also present in T cells and can be responsive, can respond to salt in T cells. And so to look at the role of T cell SGK1 in hypertension, a grad student in the lab, Alison Norlander, showed that if you see this mouse model, that if you knock out SGK1 specifically in T cells, which we did by crossing the SGK1 floxed animals with mice expressing CD4 Cre, that we had a profound protection from hypertension. So basically in this mouse model, only the T cell are missing SGK1, and SGK1 is still present in the kidney and all other cell types. And this is RT-PCR data showing that indeed we have knocked down SGK1 in the T cells, but we did not affect its expression in non-T cells. Then she subjected these mice to angiotensin II and DOCA salt hypertension. I'll show you data from the ANG2 model in the interest of time. So basically, if you take these SGK1 flux control mice in blue versus the mice that don't have SGK1 in their T cells in purple, you can see here there's a 25 millimeter mercury reduction in blood pressure in the T cell SGK1 knockout animals. So this blood pressure difference is actually clinically very significant, but you might think, well, it's still somewhat of a modest effect. Well, what's remarkable is that despite the blood pressure effect being only modest, we see a dramatic effect on renal and vascular inflammation. So here are the wild type floxed animals, and they show the expected increase that we've seen in immune cells in the aorta and in the kidney, whereas the mice that don't have SGK1 in the T cells have no increase in vascular or renal inflammation. Let's look at other NFL-dependent relaxation to acetylcholine. From this experiment, we take out mesenteric vascular rings, and we can subject them to increasing doses of acetylcholine. And as you can see here, the upward shift in this curve means an impaired relaxation. So if you take wild type animals after ANG2, they have impaired relaxation, as shown with this upward shift in the curve. But there's no effect of ANG2 on the blood vessel function of the T cell SGK1 knockout animals. And finally, we looked at albuminuria as a measure of glomerular or renal injury. And again, there was a non-significant increase in albuminuria in these SGK1 knockout animals, whereas the two control groups show the expected increase in albuminuria. So what this shows is that basically, even if you don't completely correct the blood pressure, by targeting the inflammatory cells, we can really block the end organ damage that ultimately is what is responsible for hypertension, or responsible for mortality and morbidity in people with hypertension. So now I want to focus on IL-21, which is a different cytokine, but related to IL-17. And then this is made predominantly by T follicular helper cells, but also by T helper 17 cells. And Bethany Dale, a graduate student in the lab shown here, did this work a few years ago showing that mice with ANG2-induced hypertension have increased IL-21 expression. And that if you knock out IL-21, you see a protection from the hypertensive response to ANG2. And interestingly, we think IL-21 is upstream of IL-17 and interferon gamma because these IL-21 deficient animals did not show the hypertension-induced increase in T cell IL-17 or interferon gamma that we see in wild type animals. So now we found like a hierarchy where we think IL-21 controls IL-17, which then has effects downstream. And indeed, the IL-21 knockout animals, they were protected from vascular remodeling. So this is a cross-section of the aorta. And you can see here in a wild type animal after ANG2, there's this thick fibrosis, as indicated by the thick blue staining here. And the knockout animals for IL-21 did not have this thick fibrotic response. So we then gave antibodies to IL-21 to try to deplete or neutralize the cytokine. We did this after the mice were allowed to get hypertensive. So we give them 4 weeks of ANG2, and starting at week 2 of ANG2 infusion, we gave antibodies to neutralize IL-21 or isotype control antibodies shown here in red. So you can see here, when we neutralize IL-21 with the antibodies, there is a decrease in blood pressure, and then this also completely reversed the vascular function. So this blue line shows you that the vessels are now relaxing normally after receiving the antibody treatment, and the vascular inflammation is also abolished. So that's the appear that anti-cytokine therapies can not only lower blood pressure, but even halt or reverse the end organ damage. So the question I often get is, what comes first? Is the chicken or the egg? So is it hypertension causing inflammation, or is it inflammation causing hypertension? So I think the answer is both. So it's basically a feed-forward cycle that works in both directions. So hypertension, we think, activates the immune system, which then causes, as I showed you, renal and vascular damage. And renal and vascular damage can cause further hypertension. However, it can go the other way too. So hypertension probably is causing some damage, and this damage could be inciting an immune response. And the immune response can be causing further hypertension. So it's definitely a feed-forward system, but we think that if we can block the cycle, at some point, that we can have a significant effect on our patients' morbidity and mortality. Another question I often get is there a neoantigen in hypertension? Like, so is an autoimmune disease, basically? And so work by David Harrison and Ned Carabo in the lab in our group have shown that actually there possibly is a neoantigen, or something that behaves sort of like a neoantigen, which is that you have oxidation of arachidonic acid that occurs in hypertension that forms these adducts called isoketols or isolevoglandins. And these are highly reactive gamma ketoaldehydes that can adduct to protein lysines. And they've shown that these isoketol adducts are increased in immune cells of hypertensive people, and that they seem to act as a neoantigen, and that they're presented on MHC1 or MHC2, and they can then drive T cell proliferation and T cell IL-17 and interferon gamma production. So there's still more work to be done here, and they have a lot of ongoing studies to try to elucidate what this neoantigen might be. But that is a theory that's out there that this could be autoimmune driven. So what are some current treatments for hypertension that may alter immune function? Well, believe it or not, certain treatments that we currently use, like ACE inhibitors, actually have some effects on immune cells. So this group showed that if you block angiotensin converting enzyme, that you can actually induce these good regulatory T cells, and that you can decrease these bad Th1, Th17 cells. Also, this group here showed in 2014 that spironolactone, that we commonly use for resistant hypertension patients, can decrease DOCA salt-induced activation of T helper 17 cells, and can decrease IL-17 expression. So let me walk you through this interesting experiment here. So after 16 days of this DOCA salt treatment, which raises blood pressure, they show that IL-17 mRNA goes up in the heart. But if you give spironolactone with DOCA salt treatment, the IL-17 mRNA goes dramatically down. So spironolactone seems to be anti-inflammatory by decreasing IL-17A and Th17 responses. They then said, well, this is just a blood pressure effect. So they used a triple therapy of reserpine, hydralazine, and HCTZ, which lowered blood pressure to the same amount that spironolactone did. But as you can see here, the effect on IL-17 was much less. So there seems to be a specific effect. It's not just lowering blood pressure. That certain drugs like ACE inhibitors and spironolactone are having specific effects on T cells to modulate IL-17 expression, and this seems to be very important. Also, it's been shown that melatonin, interestingly, can regulate this Th17 T regulatory balance through the regulation of clock genes in T cells, and that if you give melatonin, this can block Th17 differentiation. So in this group, they used a mouse model of multiple sclerosis, which tends to show some seasonality, as we see in cardiovascular disease as well. And melatonin actually decreased multiple sclerosis severity in this mouse model. And we have an ongoing project in the lab right now that I have a postdoc working on to see if melatonin might have beneficial effects in our hypertensive mouse models. Interestingly, a human study showed that if you give long-acting melatonin, it actually does lower nocturnal hypertension by about 5 to 6 millimeters of mercury. And we know that nocturnal blood pressure is perhaps even more important than daytime blood pressure in terms of predicting cardiovascular events. So finally, is immune modulation and an inflammatory target in the future for the management of hypertension? So we can take some lessons from two very recent large trials that looked at the role of anti-inflammatory therapies in atherosclerosis or coronary artery disease. The first one is the CANTOS trial that you may have heard of. It received a lot of media attention. And this trial, they used an inhibitor, interleukin-1 beta. And they found a very modest effect on reduction of cardiovascular events. It was fairly modest, but it was significant. However, the FDA felt that this effect was not enough to give it approval. So currently there's still no FDA approval for canakinumab for the treatment of heart disease. Subsequently, the CIRT trial looked at methotrexate, and this is a drug that's used in rheumatoid arthritis as a kind of a generic anti-inflammatory drug. And this had no effect on cardiovascular disease. I think the lesson here, though, is that we need to really be thoughtful in what drugs we choose and how we choose to block the immune system. So perhaps methotrexate or IL-1 beta are not the right targets, that we should be really targeting other factors like perhaps IL-17. But interestingly, there was a sub-study done of the CANTOS trial that showed that even though canakinumab had no effect on blood pressure, interestingly, if you stratify the patients in CANTOS by their blood pressure quartile, those with the highest blood pressure seem to have the greatest benefit, although it was not significant, but it was a trend to a greater benefit of canakinumab in those patients with the highest blood pressure. So that is something that we thought was pretty interesting. Also, a very small study that's done many years ago now showed that CellCept, which is an immune suppressant drug, can actually improve hypertension in patients with psoriasis. But again, this is a very small trial, and we have yet to validate this in larger studies. So we asked the question, can IL-17 inhibitors have beneficial effect in hypertension? So there are currently, so IL-17 has two isoforms, A and F, that can bind as homo or heterodimers to target tissues to the IL-17RA and RC receptor subunits. And there are drugs out there that block IL-17 signaling, such as secukinumab, which is a monoclonal antibody to IL-17A, and brodalumab, which is a monoclonal antibody to IL-17 receptor A. And these drugs have been shown to have very important effects in blocking psoriasis, which is a IL-17 mediated disease, but have not been studied in a cardiovascular hypertension context. So we obtained mouse analogs of these antibodies, and we did the same experiment that I showed you before for IL-21, where we induced hypertension for 4 weeks. But halfway through, we initiated the antibody treatments to see if we can lower blood pressure by inhibiting IL-17 signaling after the blood pressure has already come to full effect. And what you can see here is that they indeed, if you give an antibody to IL-17A, shown in green, or the IL-17 receptor A, shown in blue, that we can lower blood pressure. And importantly, look at markers of vascular inflammation, renal inflammation, albuminuria, and fibrosis. These are all down in the groups that receive the anti-IL-17A or RA treatment. So what is the best inflammatory target to follow in human hypertension? Well, I'll show you that IL-17A is definitely a potential marker that we could try to follow. And we showed in our original paper that people with hypertension have 3-fold higher levels of serum IL-17A, and other groups have also shown an increase in circulating TH17 cells and IL-17A levels. But we want to know if there are some other markers as well. Well, actually, let me go back. So this study, we actually took T cells out of people, and we put them in culture for 3 days, and then we measured the cytokines that were secreted. And what we found was that IL-17 secretion from these cultured T cells correlated with blood pressure at the time of blood draw. And the same was true for IL-21. So this could be a potential marker to follow, although it is difficult to follow these levels because they're highly variable. So we want to know if there's a specific cellular marker to follow. I'm not sure I'm going to skip over this one here. And so to answer that question, our goal is to use high-dimensional profiling of single cells, followed by unbiased analysis to identify any differentially expressed, potentially novel cell populations in hypertensive people that could then lend insight into both diagnosis, pathology, and perhaps be a biomarker to follow. So to do this, we obtain peripheral blood from people with and without hypertension, and then we label them with these heavy metals. So basically, these are antibodies to surface proteins that instead of being tagged with a fluorophore, like in traditional flow cytometry, these antibodies are tagged with a rare earth metal. And then you pass this through a nebulizer and ionizer, and you filter it, and then you get this cloud of ions that represents each individual cell. And then when you pass this through a mass spectrometer, what you can then get is basically a list of all the protein markers that the cell possessed. And then we do some complex bioinformatics analysis to determine how these cells can be grouped together based on similarity of marker expression. And so the goal of this project is basically to see if we can find some kind of unique cell population in hypertensive people. And indeed, when we did this, we found that there are actually 29 different clusters of immune cells that we can identify that are mostly different T cell subsets. I'm not showing you the rest of the data here in the interest of time, but we found 3 different populations that are up or down regulated in hypertension. So we're now conducting some validation studies of these populations and looking at what the effects they may have in a mouse model of hypertension. And so questions that still remain, though, are, what is normal blood pressure? It seems like, the lower the better. And how low should we go? And do we need an inflammation goal to follow in addition to a blood pressure goal? And if so, what is the ideal inflammatory biomarker to follow? And how do we get there? And is there a role for anti-inflammatory therapies as an adjunct treatment for hypertension? And if so, which ones? As Winston Churchill said, this is not the end. It's not even the beginning of the end, but it is perhaps the end of the beginning. So with that, I want to thank our funding sources and my lab members, who's a combination of past and present people in the lab, and my collaborators, and Dr. Harrison and his group for his mentorship. And I want to take any questions.
Thank you, Meena, for that outstanding talk. Excellent. There are time for a few questions. If you want to put them in the chat box, or if you'd like, just feel free to unmute yourself and ask Dr. Madhur a question.
So I stopped the sharing. I can't see. There we go. Now I can see the chat box.
Hi, Dr. Madhur. My name is Dr. Sen. I'm one of the endocrinologists at GW. So very nice talk. So when you look at your mouse model of hypertension, have you looked at the metabolic changes that might happen concurrently? And if so, if there is some metabolic changes, such as, let's say, glucose parameters, does that affect the immune response per se?
So we use the ANG2 model and the DOCA salt model, and in these 2 models, we actually have not looked at the glucose tolerance or any kind of insulin clamps. We haven't done those studies, but there is evidence that immune cells are obviously important in diabetes, especially in type 1 diabetes, and so that's a good point.
Thank you.
Meena, I have a question. I was really intrigued by your immune phenotyping of hypertensive patients, and that work, which looks really exciting. So in terms of the field moving into identifying particular inflammatory biomarkers, what are your thoughts with do you think, in terms of, it's obviously going to be important for stages of hypertension, right? In terms of how the immune system is being activated and progressing to a state of chronic inflammation. do you think that possibly, I don't know if anyone's doing this, but I'm just thinking of it in the context of stages of hypertension. For example, so you look in that population of all hypertensive individuals. It may be important to compare that database to a prehypertensive population of individuals. And then to add that, I mean, another point may be looking at sex differences as well. And to sort of hone in on potential specific biomarkers that could be important for preventing the progression of hypertension if it's, you know, to a stage of chronic inflammation.
Yeah, so over here, we actually did get this question from one of our reviewers. We broke this down by gender in the sex question. This is for the IL-17 study. Oh, it's not shown here, but we actually did break this down by gender. It doesn't seem to be a gender difference in these measurements, at least. So I had another graph that's not here, but where we have the females in red, males in blue, and it's all mixed up. So there's not a clear gender difference in this assay, in the IL-17 production. In terms of your question of pre-hypertension to severe hypertension, there seems to be a linear relationship between the level of blood pressure, so starting, so, you know, 110, 120, 130, 140 to 160. And we didn't have too many people with really high blood pressures in this group. But there seems to be a linear relationship between the blood pressure level and the immune activation. But definitely that is a good thing that we should look at and see if maybe there are if there's more of this immune activation, the more resistant you are, and what those changes are between males and females potentially.
Yeah, no, yeah, and you mentioned about diurnal, the importance of nighttime blood pressure, right?
Yes.
And in these individuals, are these blood pressures taken 24-hour periods, or is it?
This was just taken at the time of blood draw.
Oh, sorry. Okay.
Yeah, so the levels of IL-17, IL-21 correlate to the blood pressure at the time of the blood draw.
Okay.
So that was kind of interesting. No, it was somewhat unexpected too. We didn't think there'd be such a strong correlation with the absolute level of blood pressure, but there was a pretty remarkable, you know, R 0.4 and 0.38.
Yeah. Very nice. So let's see. So there's a question from Sarah Roberts. Thank you. The question is, what supplements do you recommend for your hypertensive patients to reduce their inflammation or improve their immune response?
So I can't tell you that just yet because we're doing the studies right now, but we want to see if melatonin, particularly long-acting melatonin, because it's been shown to dampen Th17 responses. So we're doing experiments right now in mice to see if giving them long-acting melatonin can dampen this Th17, IL-17 activation in hypertension. So maybe, you know, in a year or two, I can come back and tell you if that worked or not, and if you should be taking melatonin or not for your blood pressure. So other supplements, there are these, there's a thing called TOBA, which is a kind of an isoketal scavenger. And so there's clinical trials going on right now at Vanderbilt to see if scavenging these isoketal adducts, which we think might be a neoantigen, if that can be protective. And those scavengers are actually kind of like an herbal supplement, so that they're found in nature. But you have to take them at pretty high doses, you know, to do this. But we have a trial going on now to see if that supplement might be beneficial. But besides the TOBA and the melatonin, I don't know of any supplements per se that that we have proof is beneficial right now.
Okay, thank you, Meena. So we've got another question for you from Patricia Fry. Was there any correlation between elevated IL-17A or IL-21 levels and BMI?
So I'd have to go back and look. We did collect that data, and so in the graph we adjusted for BMI. So we found a different correlation between the cytokines and blood pressure after adjusting for age and sex and BMI. So it was one of our adjusters. Whether it actually correlated, I'd have to go back and look at that data and see. I don't remember offhand.
Okay, thank you.
I have a question.
Yes.
Better. Yeah.
Yes. Go ahead.
This is better. I have a question, like opposite view. How is it in the how the blood pressure changes in the people who have, let's say, normal blood pressure and are treated with the anti-inflammatory drugs because of the inflammation, not because, yeah? So the opposite point of view.
So it depends which anti-inflammatory drugs you're talking about, because there are so many different types and they have so many different types of effects. What do you have a specific anti-inflammatory drug you have in mind?
No. It is in general because the inflammation, you showed that basically the inflammation is responsible for the increased blood pressure.
Okay, so it's not. So I think it's not really general inflammation. I think we have to be very specific in which arms of the immune system we target. So for example, it's just shown that cyclosporin that's used in people who've had like solid organ transplants. We use cyclosporin to suppress their immune system so that they won't reject their transplanted organ. So paradoxically, we see actually an increase in blood pressure in people who take cyclosporin. But what we think is happening there is that if you look closely, even though the overall numbers of T cells are reduced by cyclosporin, it's actually a shift in the Th17 Treg ratios. The patients who get cyclosporin actually have more Th17 cells and less Treg cells. So we think that is why they have worse hypertension. Now, when we gave our specific IL-17 blocker, or if you knock out IL-17, let's say, by a gene knockout in the mouse, we don't see any effect on baseline blood pressure. So I don't think that we're going to make normal people hypotensive by blocking these pathways. In terms of, and for example, we know the NSAIDs, like Motrin and Aleve, all those things, they are quote unquote anti-inflammatory, but they raise blood pressure. But we think that they do that through their effects on the kidney and by increasing the sodium and water absorption in the kidney. So we really have to be careful when we say anti-inflammatory. It's not really one bucket group of drugs. So each one has its own pros and cons and can affect the immune system in different ways. So I think we have to be very selective in how we block the immune system to get the most benefit.
Thank you.
Yeah, on that note, we have another question, Meena, in terms of anti-inflammatory therapies. Mm-hmm. And this one is from Sarah Roberts. Thank you for your response. Previous question. This question is, what do you think about fish oil and its anti-inflammatory effects?
Oh yeah, that's a great question. So fish oil in a lot of initial studies kind of had mixed effects. It was good in some studies and bad in some studies. It wasn't, it had mixed effects, but now more recently, there's this drug called Vascepa that has come out, which is a very concentrated type of fish oil. And that seems to be very beneficial, for cardiovascular disease. We have not looked at Vascepa specifically in our hypertension models, but that's definitely very interesting. But definitely this concentrated fish oil seems to be very, very important, or seems very beneficial in atherosclerosis and in hyperlipidemia.
All right, thank you. Quick question on your mouse studies, and going back to diurnal blood pressure patterns, do you see any differences in your IL-21 or your IL-17 knockout in terms of the patterns of blood pressure in your mouse studies? They
still do have the day-night variability, but we have not looked closely to see if we have any specific, specific differences in that. But I have a collaboration going on right now with Jennifer Pollock, where we're trying to see if maybe a high-fat, high-salt diet, which she shows has blunted the blood pressure rhythms. We're going to see if that blunting is more pronounced in the IL-17 knockdown animals.
Okay, interesting. Sounds good. Does anyone have any more questions for Dr. Madhur? No? Well, thank you again, Meena. We really appreciate you telling us about your work.
Thank you.
And look forward to seeing you again sometime. Hope everyone stays well out there. And in the chat box, Jeanette has put a link to other other lectures, seminars that we have on inflammation as part of this cross-disciplinary seminar series. So you can feel free to click on that if you're interested in other topics. And on the event webpage, we have some upcoming events too if you want to check out. So thank you very much again, Meena.
All right, thank you.
Take care.
Thanks.
Bye.
Bye.